I'm very excited for today's presentation. We're very fortunate and grateful to have Dr. Justin Maykel, Professor in Chief and Streeter DeFutis Endowed Chair in Surgery from UMASS Memorial Medical Center. So he's going to talk to us about complicated diverticulitis. And Dr. Maykel, I hand it over to you.
Thank you, Dave, for the introduction. And I'm excited to participate in Surgery Live. I've been a participant actually since it was initiated a few months back, and I've learned quite a bit, and I enjoy the platform. And today, what I've done is chosen a case of complicated diverticulitis to discuss. Understand these cases can be complex, and there are a lot of different ways to manage them. And hopefully, we'll have opportunity for interaction and discussion, and see how people choose to handle these cases from around the world. So when we talk about diverticulitis, we tend to bunch it into two different categories: uncomplicated and complicated. And complicated cases typically deal with free perforations, abscess formation, strictures, and then fistula formation. Next slide. And the reason why we tend to enjoy this probably more than our patients is that typically the solution for complicated diverticulitis results in surgery. And obviously not for all cases, but particularly for patients who develop strictures and fistulas, surgery is really their only option for cure. So I'm going to use this case presentation to walk everybody through a case of complicated diverticulitis. And then, like I said, hopefully we'll have an opportunity to exchange some ideas and concepts with regards to how these cases should be managed. So this was a 50-year-old woman who presented to our emergency department with 3 days of progressive left lower quadrant abdominal pain. This acutely worsened on the day of presentation, and that's what brought her into the emergency room. She had had no prior episodes of pain similar to this, and she had not carried a diagnosis of diverticulitis. And at age 50, she still had not had her first colonoscopy. As you can see here, she was relatively healthy, well-controlled hypertension, some mild COPD from tobacco use. She had no prior abdominal surgery, and she was only on 2 medications, some inhalers and some lorazepam for her anxiety. So on examination, she had a low-grade temperature of 100.4. She was slightly tachycardic, 109. Her blood pressure was normal. She actually looked quite well. She did have impressive left lower quadrant tenderness with guarding in the left lower quadrant, but the rest of her abdomen was completely soft and non-tender. She had an elevated white count of 14.5 with a slight left shift, and her hematocrit was stable at 37. Next. So like all patients who come through any emergency room around the world, she had a CAT scan. And you can see here that the CAT scan shows pretty impressive sigmoid diverticulitis with a wall thickening surrounding inflammation and stranding in the fat surrounding the sigmoid colon. And you can see the arrow notes this, what was measured to be a 2.5 centimeter intramural abscess, or abscess within the wall, the thickened wall of the colon, without any free air or free perforation. And although there was some edema and obviously a very narrow lumen, there was no proximal dilation or any evidence for significant large bowel obstruction. So the question here is what to do next. And I don't know if maybe we can go to a poll and allow everyone who's participating to go through these 3 different options of exactly what to do in this particular situation. So number 1, admit for intravenous antibiotics. B, place an IR drain into this abscess cavity. Or C, go to the operating room for management.
All right, so we got some results here. 7 people have voted. 6 say admit for antibiotics, and 1 says IR drain. No one wants to go to the operating room. Let's go around. Let's talk a little bit about people's thoughts here. So, see, Dr. Joe Trunzo is here with us. Dr. Trunzo, what would your initial management be here? What are your thoughts between antibiotics, drain, or operating room?
Well, with the size of that, well, thank you, Dave. With the size of that abscess, intramural, if she's not acutely ill, I don't know that she needs to go rush into the operating room, and I don't see that's a really good size abscess to drain percutaneously. So typically, I would try to treat through that with IV antibiotics and see how she evolves.
Great. Dr. Rogla, sorry, I know we were too quick on the trigger over there. Sorry that we closed the poll too soon, but let's go to you and your group over there. What do you guys think about how you would manage this?
Yeah, I think I would agree with the voting. We would probably admit the patient, IV antibiotics, and send her for interventional radiology for drainage.
So you would think that you would drain this abscess. It's listed as intramural. Some people do think you should drain intramural abscesses. Some do not. What are your thoughts about when it is intramural?
Maybe give her some course of antibiotics and rescan her at some point.
Fair enough. Fair enough. Did anyone else think for IR drain? There was, I don't mean to call out the one person who voted for it, but show yourself and defend yourself if you'd like. No takers. How about you, Dr. Maykel? What are your thoughts on intramural abscesses and whether they should be drained or not? Does size matter? Does specific location? What are your thoughts?
Yeah, so, this is one of those situations where it leads to a conversation with our interventional radiologists. And I would say that the hesitance on their part is they're always concerned about placing a drain into these intramural abscesses because they're concerned about creating a colocutaneous fistula. And so they tend to meet with resistance. And my response to them is that's fine. I don't have a problem with that. This patient is most probably going to require an operation anyways. And if you create a colocutaneous fistula with a drain placement, we're going to manage it at the time of surgery anyways. So if we go back to the presentation, so in this particular situation, mainly because of the size of the abscess and how the patient was doing, we opted to simply admit and put the patient on bowel rest, started intravenous antibiotics at our hospital. That first line treatment is third generation cephalosporin and Flagyl, so ceftriaxone and Flagyl, IV fluids, and serial abdominal exams. We monitor the patient closely. Next slide. So the patient actually did well with this approach. Over the ensuing several days, she had less pain. Her tenderness improved. I wouldn't say that her tenderness resolved, but it improved significantly. She no longer was having any low-grade fevers. Her heart rate was back into the 80s with some hydration. We were actually able to slowly advance her diet all the way up to some regular food. Next. The issue, or the one thing that stood out, is that her white count remained elevated. It started around 13,000, and despite her clinical improvement, it rose to 20,000. So after a week of being in the hospital, we opted to go ahead and repeat the CT scan. Next slide. So you can see with these representative images from her CAT scan that the situation had changed significantly. And so instead of having a persisting, well-contained 2.5 centimeter intramural abscess, basically that abscess ruptured, and she had developed not only ongoing abscess, which you can see in the left photo, but now she had free fluid and rim-enhancing collections, both in the right lower quadrant and in the pelvis. And so although clinically she had improved, radiographically, her infection had progressed. So what do we do next? So I'd like to move on to the next polling, and the options that we have listed here are A, to continue or change the antibiotics, B, now place IR drains, or C, now bite the bullet and go to the operating room.
All right, 24 participants, excellent. All right, so nobody wants to just continue with the current course, change antibiotics. I think most people have recognized that the situation has changed, as Dr. Maykel said. I'm pretty split. 14 people say IR drain placement, and 10 people say, let's go to the operating room. Okay, so talk about some different options here. So Dr. Steele, what did you vote for? What's your thoughts between IR and really try to drag this out? I mean, she's now at day 7 in the hospital. Do we bite the bullet? How do you go about figuring that out?
Well, thanks, Justin. Appreciate the opportunity and great presentation. So the thing about abscesses is that it's pretty clear that you're talking about a little bit like real estate. So size and location matter. Less than 3 centimeters has been associated with clearing with antibiotics in multiple different series, most of them retrospective, with just antibiotics alone and don't need to necessarily have percutaneous drainage. There's also a difference, and this has been in the Ambrosetti study that's several years old now, but a very nice, eloquent study that talks about the differences between mesocolic abscesses and pelvic abscesses. And in general, mesocolic abscesses tend to do better than those who have pelvic abscesses. If you combine that on the data that's associated with urgent surgery in terms of both mortality, which we don't think of a lot with diverticulitis, as well as morbidity, and combine that with the rate of not only temporary stoma, but permanent stoma that never get taken down, what's clear from the literature is that when you have a pelvic abscess like you have here, they tend to do worse with antibiotics alone. They do better associated with getting a drain in place. A lot of times, unfortunately, it's transgluteal. And if you can get that patient out of the acute setting, continue their antibiotics, calm them down, and then I'm sure we're going to get into the data about do you do an interval colectomy if you could get them through or not? And that's a whole different question. We can serve that later. But this is a patient that would serve better by getting a successful percutaneous drainage with the understanding, and what you should tell your patients, if you follow those patients out, about 1/3 of patients who have a drain placement will fail.
Great, thank you. So we got a vote there for interventional radiology there, and for anybody who voted for the operating room for a different point of view, feel free to speak up. I will say there's different options that people would talk about in the operating room versus a resection with an end colostomy resection with a primary anastomosis with an ileostomy. What's fallen out of favor, but some people still consider it as laparoscopic lavage. Dr. Cesar Restrepo, I know you've been joining us for several episodes of Surgery Live. What are your thoughts on this case? Do you think we should bite the bullet and go to surgery, or does Dr. Steele's plan of IR drain sound good to you? I think you need to unmute your.
Well, thanks for this nice opportunity. In Panama, myself, what I would do is take this patient to the operating room. We don't have all the tools you have, all the techniques, and the safest way to go is to take this patient to the operating room immediately. Well, a few hours. Thank you.
Great, thanks. So Dr. Brad Champagne has found his way to a working camera and computer. So now we will ask him about his opinion on OR versus laparoscopic lavage or other type. And Dr. Restrepo, thank you. Resources and availability of IR definitely contributes to that decision.
Thanks, David. Yeah, so come back. I don't know how much you could hear from my other discussion. I agree with Dr. Steele that in this case, my preference would be, for all the reasons he mentioned, radiology and interventional procedure with drainage. Laparoscopic lavage in my practice is something that has a very limited role. It's kind of something that I back into. So the cases that usually once or twice a year at most, I take someone to the operating room with generalized peritonitis, but they do not have significant comorbidities. They're not significantly hemodynamically stable. Put a camera in, and it's what we used to call a Hinchy 3, just purulence, and there's no feculent peritonitis. I'll usually watch that patient out, mobilize momentum, and kind of stabilize the situation, and that's worked really well. Those are few and far between, but there are still, I think, a very limited role, and in that case, you save a Hartman procedure.
Great, thanks so much. All right, let's go back to the case, and Dr. Maykel, let's see what you guys did.
Okay, next slide, please. So in this particular case, we're fortunate to have the resources available to us. So that's a really good point that, not every hospital and every setting has interventional radiologists who are willing to place drains such as this. Now, the abdominal drain was a pretty straightforward one, but you can see here the pelvic drain, the one on the right, is a transgluteal. It was a bit of a challenge to get it into the abscess cavity, but both drain placements were successful. The abdominal drain pulled off about 20 cc's of pus initially, and the one in the pelvis, which is more dependent, pulled out 100 cc's of pus. Next slide, please. So basically, we controlled the situation. We maintained the patient in the hospital. She slowly improved. Her white count normalized. Her tenderness resolved. Again, we had her on regular food, and after about 4 days after drain placement, we sent her home to complete a total of a 14-day course of oral antibiotics following drain placement. So we maintained very close follow-up. Our typical protocol after hospital discharge is a telephone call within 48 hours. She followed up in the office 1 week following discharge and was slowly improving. And then she followed up 2 weeks later. And at that time, she had zero output from the abdominal drain. It had really cleared up, and she had minimal purulent drainage, but persisting purulent drainage from the pelvic drain. Next slide. this is our third and final poll, if we could call it the poll. So what do you do now? So these two drains are in place. The patient is clinically improving. The upper drain is really not productive. The lower drain, the pelvic drain, is productive. Do you remove them? Do you leave them in place? Do you repeat the CAT scan? And what about repeating the CAT scan with a drain study whereby you inject contrast into the drain and see if there's any communication with the bowel lumen?
All right, looks like the poll has ended. We'll see the results here momentarily. All right, so there's actually a wide variety of answers here, which is great. The most popular, so of the 22 people who voted, the most popular was people used their test-taking skills and went with the longest answer and used repeat CT drain with, repeat CT scan with drain study. That was 10 people. 7 people said repeat CT, 3 people said just leave the drain, and 2 people said remove the drain. I think, drain management is one of those things that I think everybody has some strong differing opinions on. So I want to go around the room and talk about what are some of the things people are thinking. Dr. Sarah Vogler, I see, is logged in. Dr. Vogler, if you're able to unmute, I wanted to get your opinion on how you manage your drains post-operatively in complicated diverticulitis like this.
Can you hear me?
We can, yes.
Okay. So I would say a drain that's not putting anything out probably doesn't need to be there anymore. So I think that's an easy answer on the one that's not doing anything. The other one, I would prefer to have imaging before I decided if I was going to take it out, since there's some sort of a process that's still feeding into that drain.
Excellent. There's one comment that came through. What about the role of laparoscopy to drain an abscess that IR cannot reach? But clinically, the patient has improved but not completely resolved. I think you're sort of along the lines of laparoscopic lavage and versus just laparoscopically draining that abscess. What are your thoughts about that, Dr. Maykel? Is that something you ever do in your practice?
I think it would be a rare situation to have to do that. I'm not saying that I haven't and that I wouldn't. And if they're like, in this particular situation where the patient's improving, I prefer not to go to the OR because of the high likelihood of requiring a stoma. I think that's a reasonable option for controlling these abscesses. If the IR can't get to it, then oftentimes we may have to do that surgically.
Right. And so, okay, Dr. Trunzo, how about yourself? How would you manage the drains in this setting? Would you just pull them? Do you like the imaging? Do you want a drain study? What do you think?
My opinion on it, so quite similar to Dr. Vogler. The one drain that really wasn't draining probably can be pulled, but with the other one still feeding something, I would re-image and see if you actually really have control of the sepsis. And and just as an aside, the one thing about these cases that kind of drag out, these patients are staying sick and they're not getting better. And sometimes you do have to pull the trigger and say, okay, they're just not doing well enough with this medical management drains, prolonging their course because they want to get past it. So I think that's a conversation you have to talk with them about, whether that also helps me decide about how long I'm going to try non-operative versus going forward and just, even though it means a colostomy.
Right. Dr. Maykel, let's see what you did and take us to the finish line here. You're still muted, Dr. Maykel.
All right, let's get back to the presentation, please. Okay, great. So, so we chose to repeat the CAT scan, and we did remove that abdominal drain. You can see here on this left slide that all the fluid in the right lower quadrant had resolved. There's still ongoing inflammation and thickening and straining of the sigmoid colon. I mean, this is, although the patient presented acutely, this is clearly a process that's been going on for quite some time, probably unrecognized by the patient. And you can see on the right side that the pelvic abscess has resolved, but the drain is still in place. And I will say that my personal management of these drains, it gets back to what Dr. Steele said about real estate, is that these pelvic abscesses are much worse than the abdominal abscesses. And in my mind, it's all about having a distal area to connect to once we get into the operating room, and not removing these drains prematurely so that the abscess can simply reaccumulate and you go all the way back to ground zero. And so, so I tend to leave these drains in place until we get to the operating room, even when there's minimal output, because of my concern about reaccumulation of the abscess. And earlier in my career, I had plenty of patients where we did drain studies, we confirmed there was no communication, the drains dried up, we pulled them. and then they develop recurrent abscesses. And I think that once you have control of these challenging abscesses, I prefer to leave these drains in until we get to the OR. So in the interest of time, I think we'll continue with the presentation and go to the next slide. So, basically I had a conversation with a patient and it was time to start planning for surgery. We started with a colonoscopy. The patient was prepped. And the way I typically do this is we give the patient a single prep, we do a colonoscopy, and then the following day they're already prepped to go to the operating room. So we brought her to the endoscopy suite, we performed a colonoscopy, and the rationale behind this is to confirm the diagnosis and rule out any other potential causes such as malignancy. We encountered a tight stenosis in the sigmoid colon. The sigmoid was absolutely fixed in place. There was no way we were ever going to be able to maneuver beyond this. No mass was identified, and so we aborted at a flexible sigmoidoscopy. Next slide. And the following day, which was essentially 2 months, and we can talk about timeline, we took the patient to the OR 2 months following IR drain placement. We started with, I had our urologist there for cystoscopy and bilateral ural stent placement. And I will tell you that I will do this in these complicated diverticulitis cases. It's not always all that helpful, but in this particular case, it was extremely helpful because of the degree of scarring inflammation in this woman's pelvis to have that, particularly that left stent in place. We started laparoscopically, not necessarily because I thought I was going to be able to accomplish the operation laparoscopically, but it gave us a good opportunity to lyse adhesions. She actually had pretty extensive intra-abdominal adhesions extending all the way to the liver, and it seemed to me that at some point the perforation wasn't just localized to the pelvis, but she had developed adhesions from the prior perforation. We mobilized the small bowel out of the pelvis, and we had to basically disconnect these small bowel loops from these chronic pelvic abscess cavities. And while there, we mobilized the entire left colon in the splenic flexure so that when it came time to making our abdominal incision, I was able to do it all through a lower midline incision as opposed to having to extend all the way up into the upper abdomen. When we got in, this was an operation that absolutely could not be performed laparoscopically. The sigmoid colon was like a rock stuck in the pelvis. I was able to convert to open. We used a combination of blunt and sharp dissection. We freed the ureter from where it was attached to the mesentery of the left and the sigmoid colon. The inflammation actually extended all the way halfway up the descending colon and all the way down to the cul-de-sac. And so the thickened sigmoid and upper rectum all had to be resected. As we mobilized, we encountered the left ovary and tuba, which were also adherent, which had to be resected and blocked. And once we had mobilized below the anterior peritoneal reflection, we were surprised to find that the rectum was actually relatively soft and pliable. And so we divided the mid-descending colon, we divided an area of the mid-rectum, and then I had a decision to make. And the decision was, do we give the patient an end colostomy and come back another day, or do we go ahead and move forward with an anastomosis? Because of the complexity of this surgery and the challenges that we encountered, I thought it was going to be particularly challenging to come back at some point and dig out this rectum and do an anastomosis. And I felt that the quality and the softness of the rectum below the peritoneal reflection was adequate for an anastomosis. We used a 25 EA stapler because, adding insult to injury, the patient actually had a very tight anal stenosis, and it was really the only size stapler I could get to reach up there. So we did a side-to-end 25 EEA colorectal anastomosis. It looked healthy. It was under no tension. The tissue seemed healthy, and the leak test was negative, and I opted against diverting the patient. The anastomosis sat at 11 centimeters from the anal verge. Next slide, please. We put the patient on an ERAS protocol postoperatively. This was not a typical elective surgery, so instead of going home on day 3, which is our typical day, the patient went home on day 5. Next. Pathology confirmed acute sigmoid diverticulitis with serositis and abscess and foreign body giant cell reaction. The margins were healthy and viable. There were 2 tubular adenomas within the specimen as well. Next slide. The patient's been seen in follow-up. She's actually doing quite well. And the question, in conclusion, we can open this for discussion, is this a success? The patient ended up having 1 surgery, didn't have to have a stoma. She had a short hospital stay following the operation. So from that perspective, I would say, yes, this was actually a success. Next slide. But at the same time, the patient required 4 different CAT scans, had 2 hospitalizations that, which added up to over 2 weeks in the hospital, 2 IR drain procedures. She had to live with this drain for 2 months, and believe me, it was a major complaint of hers. And she had a failed colonoscopy. So although I think at the end of the day we were successful in getting this patient through with this approach, there are different ways to manage this. Like one of our participants said, we could have gone to the operating room sooner. And so I guess the question to the group is, do people feel like this is a success? Are they happy with this outcome? Or was the expense too high in order to get this patient through? And I'll send it back to our moderator, Dr. Rosen.
Great. Thanks, Dr. Maykel. So Dr. Vogler, what are your thoughts here in terms of both from a patient clinical experience and also overall the time, the finances, the cost? Do you think this was the right management? Would the operating room earlier have been cheaper? I mean, you would have probably needed a stoma and another operation. What are your thoughts here?
So I would say my personal opinion is I try to avoid a stoma at all costs, partly because of what Justin said, is the idea of going back and digging out the rectal stump is a little bit of a nightmare, probably my least favorite surgery ever. So if I can get them by, I think conservatively, even though it may require a lot of complaining and whining for a couple months, my preference would be to get them to an elective surgery where they could be hooked up.
Right. I think that's a really good point. I think also you made a good point, Dr. Maykel, although it was a failed colonoscopy, and this is a point for our residents and trainees tuning in complicated diverticulitis, as opposed to uncomplicated, there's a higher risk of a underlying colon cancer, malignancy, up to 8 to 10%. And so I think most of us would check, at least attempt to check and see and make sure we confirm the diagnosis and that there's nothing hidden in there, suspicious. And Dr. Trunzo, you mentioned earlier, sometimes you just got to bite the bullet. I think that's the hardest thing to try to tease out. And do you have any pearls or tricks as to how do you identify that patient? Because these do often drag on when you're trying to put drains and just waiting to get better. And then some patients just don't. And now you feel terrible because you've waited 10 days, 2 weeks with them being malnourished, not eating, and then you're just ending up with the operating room. Is there any way you can identify earlier which ones aren't going to fly with this conservative management?
I mean, I think it's always a challenge, and every patient's obviously going to have a little bit of a different story. I think, sometimes their underlying comorbidities might push us a little bit, one way or the other. Some of the sicker patients that we're worried about how they would handle the operation, we might drag on, but some are just doing so poorly. We just have to find a happy medium. I know it's a little wishy-washy, but it's never really that straightforward. And I think a lot of it has to do with what the patient wants. And, some patients will be saying, they'll come right out and say it. I just can't feel like this. They just don't feel well. And even if they're at home and they got a drain in, but they're still sore and they're not eating well. And even though we're kind of controlling the situation per se, we never really get them far enough out from it where we think we can get it in a one-staged operation. So I think it takes a little bit of what the patient is, how they're doing throughout the process, more than just whining that they just don't like the drain. Are they clinically getting better? Are they eating? Are they getting back to like a good function? If they're still smoldering along, their pain is still there, they're nutritionally just continuing to sour, then I think that's going to push me to take them to surgery and manage the situation. It's kind of like chronic smoldering sepsis in their pelvis versus someone that may be flourishing despite having a drain or kind of pushing them out and they're actually still doing fine. And I might be able to say, look, we're kind of on the right track here. We can get you through this one operation.
Absolutely. I think that's a very wise point. We have one comment that says, certainly was a success. I think healing without an ileostomy was risky. You mentioned about timing. Since it was difficult, it may have been better to wait longer for surgery. Dr. Maykel, do you want to comment on your thoughts of how long to wait? And obviously the decision to divert or not is an intraoperative decision that is made.
Yeah, I mean, I don't have a right answer for time frame. People talk about 4 weeks, which I think is too soon, maybe 6 weeks, 8 weeks. I think it'd be hard to push her beyond 8 weeks, particularly because of the challenges that she was dealing with managing the stone, with managing the drain and the purulent output and the smell associated with it. And, and she had actually made a nice recovery. She was back to her normal health. I mean, obviously she had this ongoing inflammatory process in her abdomen, but she was eating, she had gained weight, she was feeling strong and fit again. I felt that it was it was sort of the sweet spot of the right time to intervene before things potentially took a turn for the worse. And so, and I'm not sure that more time would have improved. You know, we treated her with a full course of antibiotics, and you know, there's just so much chronic scarring in her pelvis that I'm not sure another couple of weeks or even a month would have made much of a difference. I think the key was getting below the peritoneal reflection to a safe area that was sort of preserved from this chronic inflammation.
Right, absolutely. And Dr. Steele, last question to you before we end. Is this the best we're going to do with diverticulitis? Is there anything that we can do on this disease process? How do we get these patients better sooner, whether it's screening? I mean, we obviously don't do any prophylactic surgeries for diverticulitis or diverticulosis, but how do we get our patients and get to a point where we can manage these with better than these, you know, long, several months course?
You know, the thing that always comes up about diverticulitis, and I encourage everybody to read the latest ASCRS CPG that just came out this year. Jason Hall was the lead author on this. There's some updated and changes in there. When I give a diverticulitis lecture, I always tell people that there's probably so little we know about, or so much controversy about a disease that's so common, maybe other than any other disease. It's treated in many cases dogmatically. There's a lot of discussion, high fiber diet, low fiber diet. If you look at some of the large medicine ones, you would suggest that we don't really even know what role fiber plays. And there's some data that would suggest that actually, you know, the high fiber diet isn't as much protective as what we think. In general, some of the changes that are out there now, what seems very clear are to make the decision between complicated and uncomplicated diverticulitis. And in uncomplicated diverticulitis, for somebody that doesn't have an abscess or anything, we probably don't even need to treat them with antibiotics alone, that they do just as well with just keeping them NPO and having fluid resuscitation as you would in giving those patients antibiotics. So that's kind of a shift, and there's been a Cochrane data review on it, multiple randomized controlled trials, as well as retrospective reviews on that. The other thing is that there's emerging data that suggests that it's similar on the course of the spectrum of IBD, that potentially aminosalicylates might have an action on that. We know that there's something called diverticular-associated colitis. So to sum it up, I would say that I think this is a win. I think, you know, Justin, what I would suggest to you is that you're trying to compare it against the unknown, right? Would you rather have a stoma for 2 to 3 months or 6 months? Or if the data is right, suggests that 1/3 to 1/2 of patients never get that stoma taken down if it's a colostomy. So I think this is great care, despite the fact when we were fellows together, some of the things that you learned and did. I think you did a really nice job here. And I think that overall, you know, this is the take home for me of this is that with the polls and everything is great care, great outcome, but all of us would have treated this just a little bit differently. And there's not a lot of, there's a lot of areas that we as a group, as a collection coming together to discuss these cases can do a prospective review. For example, right now, hey, drain versus no drain. Go ahead and do you do the drain? Do you do the drain study or just pull the drain? What happens? How many often do they recur? So lots we still don't know about surgery, lots of this disease going on, and I think it's another opportunity for us to come together. But good job, UMASS. Good job, Justin.
Well, thanks so much. I completely agree. There's so much we don't know about this disease process, and which is incredible considering how common it is. Everyone treats these things a little differently. There's so many controversies we didn't even have time to get into, such as do you operate on every complicated diverticulitis after they recover, et cetera. So we'll have to save those for another time. But I want to thank Dr. Maykel for an excellent presentation. Thank everybody for joining us. And for all the residents listening, as Dr. Steele said, this is an area that we need more info, need more research. So talk to your attendings about if you have any interest in doing some projects. This is a great field to be looking into and help advance the field of colorectal surgery. So as a reminder, Surgery Live meets every second, third, and fourth Friday. We go through all the general surgery subspecialties. Our next Surgery Live is scheduled for 1 week from today on September 18th. Dr. Tom Zagustin will be talking to us about GEST and just a few surgical scenarios associated with GEST. So we look forward to seeing you guys next week. And thanks again for joining us on Surgery Live.